Well, now I'm going to turn to the human altitude studies and symptoms. At high altitude, almost everyone notices dyspnea on exertion, problems in sleeping, and fatigue with work. The severity of altitude sickness, defined as a headache, often with anorexia, nausea, and vomiting. High altitude cerebral edema, abbreviated HACE, and high altitude pulmonary edema, HAPE, are the two major problems we have at high altitude. Here's an example of chain-stoked breathing. The top line with Diamox or acetazolamide taken beforehand, bottom without, and you can see the saturation is going up and down all night long for the 6 hours recorded here. Well, in the White Mountain lab at the summit, on the left you see a cyanotic polycythemic COPD physician who was part of our team. And he's not ill, although he has a saturation of around 65 to 70%. A normal student volunteer with a saturation above 85 nonetheless has acute mountain sickness and nausea, turning him pale green, not red from cyanosis. Well, HAPE usually begins with resting tachycardia, substernal burning pain, dyspnea at rest, orthopnea, cough with pink frothy sputum, and increasing cyanosis. HAPE is often perihilar, patchy, and is seen first as diffuse shadows around the major vessels. Pulmonary hypertension from pulmonary arteriolar constriction is always present and is the probable cause. It is thought to be due to overperfusion of some areas of the lung. Well, here is Cedric Bainton's X-ray. He developed mild HAPE with his pink sputum and severe orthopnea during his first night in Cerro de Pasco at 4,400 meters. He treated himself by walking around in the hospital until he found a cylinder of oxygen on wheels with a mask attached. He took it back to the room he was sleeping in, nobody else around, so he turned it on and put it on his face and spent the next 4 to 6 hours in that bed until I found him the next morning. I was staying in the local hotel with my wife. Well, you can see the edema is always associated with acute pulmonary artery hypertension, but the actual mechanism of why it leaks is still not known. But we do know that similar sudden high-altitude pulmonary edema, HAPE, can occur in strong men who develop it when they get laryngospasm when you pull out an endotracheal tube. And they just fight very hard to get the air in, but they can't. And that probably pumps a lot of extra blood into the lung. Well, high-altitude cerebral edema can proceed through euphoria, as in the balloonist, to loss of judgment and vertigo, confusion, amnesia, vision, failure, retinal hemorrhages, hallucination, coma, and even death. Sometimes with or without hypoxia, HACE, hypoxic cerebral edema, retinal hemorrhages are relatively common at extreme altitudes like Everest Base Camp and higher. Most of them resolve slowly without any permanent loss of vision. Well, there was some idea that possibly VEGF, which is an enzyme that's brought into being by angiogenesis in a tissue that needs more blood supply, because it's a very potent vasodilator and it permits capillaries to dissolve and let blood leak out with plasma and red cells into the hypoxic tissue, for example, in a tumor. VEGF is 50,000 times more potent than histamine. But we don't know if that's really true. Well, for prevention and treatment at high altitude, acute mountain sickness is commonly treated with Diamox, or acetazolamide. 1/4 gram, 3 times a day, that reduces the Cheyne-Stokes sleep apnea that causes too much awakening at night. Pulmonary edema is usually treated with nifedipine or other pulmonary arterial vasodilators. And HACE can be both prevented and treated with dexamethasone.